Welcome to EOB, where the fine print gets airtime. We take the plan docs and hot takes one clause at a time. If benefits feel murky, confusing, or buried in law, we'll translate the jargon and call out the flaws. No spin, no sales pitch, just what benefits folks should know. Health and welfare, decoded, let's get into the show.
Well, welcome to the EOB.
Hi, everybody. Good to see you again. Julie Selesnik here with Justin Leader. And today, as a reminder, we're always here just trying to shed some light and explain benefits and how they work in a employer-sponsored health plan. So we're lucky today because
We have a special guest. We have David Balinski. Hi, David.
Hi, Justin. Hi, Julie.
Hi,
It's so
David.
good to see you. We've both known David for a long time, but David is one of the only people I say that actually went to school for insurance. Most of us just become like the Ned Ryersons of the world, if you're familiar with Groundhog Day. He actually grew up wanting to be in insurance. Is that correct?
Yeah, I was talked into it. I was recruited, but
By who? By like
Are
the
they-
insurance generals?
Yeah. Did they have like a rag with some chloroform? Like what's going on at Temple University?
it was Hank Greenberg. No, actually, he was one of our speakers. We had
Oh God. AIG. Sorry. In a former life, I defended AIG for a long time.
Well, it was Chartist for a couple of years when they
It
were
was
brand.
Chartist.
That's actually when I stopped being a defense attorney is after the economy collapsed in 2009 without casting aspersions on any one company. Part of my job became to go into already pending cases and file motions in limine saying, Your Honor, my client's name is Chartist, and if you allow the plaintiffs to refer to them as AIG, then it's going to be very prejudicial against them. So please make sure that they're only referred to as Chartist.
dear Lord.
And I did that for a few months, and I actually quit being a lawyer for 2 years after that. I was like, I can't do this. And then I came back as a plaintiff's attorney. But we digress. David, before we ask you any more questions, can you tell us who are you and what is your company and what are you doing?
Oh, sure thing. So yeah, I'll get back to why did I get sucked into this industry, but I run a company called Wire Health. Been CEO for 5 years now. The past year, I've actually grown comfortable with it. My co-founder, Jamin Ferner, said yesterday, he's like, "You've stopped telling people that you don't like being CEO." And I said, yeah, I think this has been a really great year for us.
You've accepted your fate.
I've accepted my fate. I've made it this far. There's something to be said about that. So definitely have a ton of lessons learned, eager to impart those on to a lot of other co-founders. I've joined a recent group of founders similar to your Vistage engagement.
Yeah.
Looking for peer groups to support each other. So hopefully I'm at that point that I can share a lot of lessons learned and encourage some people.
But who are you? Where are you from? Are you from? You're from Pennsylvania, right?
Yeah, no, I grew up right by the Philadelphia airport, and then moved out here to the stony banks of the Conneaut, where I lived for about 10 years, and then lived in Philadelphia.
Spell that. Conneaut.
Conneaut, you just say it. You don't spell it. Like it's a symbol.
I don't think I can
probably.
say it.
Yes.
Then I moved to Kensington in Philadelphia, paid $200 a month rent for a few years.
Holy moly.
So
The Kensington, like in the social media post kind of Kensington?
I know how to find value, and I also know karate. So
Like, so the pharmaceutical Kensington, the open air pharmaceutical company area?
So there's Kensington in Britain, it's a very nice neighborhood. There's Kensington in Philadelphia, which is up and coming. Like you could absolutely buy $1 million apartment in Kensington these days.
Oh.
20 plus years ago when I lived there, not so much. So, it's been great living in all these areas. But Pennsylvania has been my home, New Jersey for about 9 years. But, that was where I was a consultant and broker and stop loss, had a stop loss for the East Coast for a large national broker. So,
Okay.
We should have came with a bunch of stop loss questions.
Oh, we can ask him. We can quiz him.
Okay, but first tell us about what you currently do as CEO of Wire Health. What is Wire Health?
Yeah, Wire Health is a medium and severe mental illness treatment solution. It's a nationwide, panel of providers that we have that deliver outsized results and outcomes for our patients that really need help. So a lot of point solutions out there, a lot of Silicon Valley Bank, or Silicon Valley and venture capital backed solutions out there that can go on your phone, and they're for, the masses. They're for 15, 30% of your population. We're for 1% to 2% of your population, the ones that really need psychiatric care. They really need to get to the right place, get the right diagnosis, get the right treatment path. So we make sure that happens.
So if I have a suicidal teenager that's dependent on a plan and I need to see somebody like tomorrow, not 3 weeks from now, you are able to provide that solution.
Yep.
That's awesome.
And so can Wire Health be embedded with like if I'm an employer and give United Healthcare to my employees, can Wire Health be embedded into that, or does United say no? Oh,
so we can work with literally any group, including fully insured cases, if they want to pay extra. It doesn't make quite as much sense for them, but we can work with any group. We direct bill on those ASO groups, and they can pay from their healthcare funding accounts. We can marry up with stop loss if they're a large claimant for us and the plan.
Yep.
That happens with some cancer patients, but with a good TPA, we integrate well. We submit as a claim. We can install in a week generally.
Wow.
So we are crisis resolution people. I worked for a TPA for 5 years. We don't need to spend too much time on that part of my life, but
don't you love TPAs?
But
they're amazing.
You're a fire drill sergeant.
Yeah.
Always. There's always
a
a crisis almost every day.
Yep.
And 80% of the time, it's the world out there. It's providers not understanding something. It's something technology glitch. The PPM didn't do something. Hey, here's a problem. There's any of 200 reasons that there's a problem.
Agreed.
Yeah. Although I'm starting to think all careers, it's just always a crisis, because as a lawyer, everything's a crisis. But I used to be a wedding planner, and everything was a crisis then too.
What haven't you done, Julie Selesnik?
Oh my God. Well, I've never been a doctor.
Okay. Well, that's next year.
No, I would have to be able to stand the sight of blood and pass anatomy and physiology.
But you're absolutely right, though. I mean, it's crisis day in, day out. Our industry, though, in particular, there's so many things that can go wrong between the time somebody finds a provider that they think may be in or out of network, who knows, and then the provider tries to process a claim, and what happens to that claim, and then you get the PBM, and then you got coordination with stop loss, and blah, 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 blah. It's a constant state of anxiety.
And I think it's crazy. We're all pretty active on LinkedIn, the coolest of all the social media. But it's amazing to me that, we're in a community of health benefits people. And every week, someone who spends all day, eating, breathing, sleeping, health benefits has a crisis where someone in their family has cancer or something, and their treatment got denied and a pre-authorization, and they need help. And it's gosh, if it takes the entire community of health benefit professionals to come together and call everyone they know and come up with every idea. And usually, I'll be honest, those cases do get resolved, and those people do get their prior auths overturned because they've got this whole army of people working for them. But what about the 95% of the population that don't have that as part of their community? It shouldn't be this hard.
It shouldn't. And, to your point, right, we're involved in a lot of groups, right, a lot of organizations with some very smart people that have been in this business for a long time, many of which did not go to school for insurance. But every single week, somebody reaches out and they're like, I have never seen this before. It's the first time we're encountering a screw up as bad as it could be regarding a claim, things that you think shouldn't occur due to ineffective interoperability between plan vendors, stuff like that. But it can be exhausting. But I think for all of us, what I appreciate about you both is that you haven't fallen into the sin of certainty where you think that you know everything, because you will never know everything about this topic.
Ever.
Even if you go to school for it.
I'm certain about the current system is not working for us.
Oh, yeah. Okay, I agree with that. I mean, you can be certain about some stuff.
Okay.
Yes.
Thank you.
You just can't be certain about all the
Well, and the crazy thing is there's mad bipartisan support to they want to fix the system.
Everyone agrees it sucks. Right? There's not one person who's we have such a great healthcare system. I love how this thing works. It's so awesome. Not one employer, not one employee, not one congressperson would say we have a great healthcare system. Right?
No.
Are there maybe a limited number of healthcare executives at the top of
Well,
hospitals.
it depends who's funding their campaign.
Okay.
Right? Like, I mean, let's be honest. But that's part of the reason you're here today, David, is because you have continuously over the decade that I've known you come up with some pretty good ideas. Some of which you've been able to implement. Some, I mean, I'll be frank, this industry, people have taken and run with. And, you know, part of our job here is not only to educate people that listen to our podcast, but also to come up with some really cool ideas, and maybe they'll take off and catch. Would you agree?
I do. And David is a bona fide smarty pants. And, you know, we're on these listservs and he puts out some ideas about certain things that would help, if not entirely fix the system, go a long way to starting it. And very reasonable stuff that, like, it's pretty hard to disagree with. Although if you were ever on any of the listservs that we're on together, people can always disagree with any innocuous statement. But, you know, so I think we're going to talk about some of the ideas that David's been talking about recently. And, you know, maybe we'll expand on them, but about some ways that our system, if not be entirely fixed, could work a lot better. And I also came with all my best ideas, and we can talk about those too. And Justin, I am sure you also brought all your most clever ideas. So let's get them out there. Let's start with you.
Most of my comments are just absolute snark. So I don't know that I have any good ideas, but we'll see today.
No, it's hard to make this stuff fun, but it's also hard to gain grassroots support. So I think one of the things that, you know, really, you know, do we renew subsidies or do we stop those subsidies from being renewed is not the question. So the question, I'll make the statement just so we have it recorded, is what if we were to treat hospitals as utilities? Is that the thing we should be thumping? Hey, the hospitals are utilities. Could be a statement that most people agree with. Mm-hmm. What if we were to treat them like utilities? And there's 500 people out there that run hospitals that probably don't love that idea, but we can get them on board too, because there's a level of certainty, the vacillation of their revenue and the leaning on reliance of outlier clauses, and some of these things can be eliminated so that they can focus on what they need to. So I would even say, you get a good hospital executive that wants to do right by his community or her community and the people in that community and the leaders and the businesses in that community. I think you could gain some really good support even in those, you know, good leaders at hospital systems.
As resident of the state of Maryland, you know, arguably it's the only state in the country where there are any sort of treat hospitals like utilities in some ways. And maybe you can talk a little, and it works. I think it works. And it's certainly, we don't have the same types of problems as some of the other states in this country, which are an absolute crisis. But first, let's just go back a little in case anyone watching isn't, like, you know, 100% up to speed. What are utilities aside from like electricity and water? And what does it mean to be treated like a utility?
So yeah, you like to get reliable, clean water from the pipes. You like the sewers to be unclogged. There's things that everybody needs for human life, and that's, you know, part of the crux of the argument is, you know, do people deserve, for being alive in America, healthcare access, or do people not deserve healthcare access? We can dig into that. That is a crux of the point where people start to differ. But regardless, you know, having that, you know, the more important point is when you don't have consumerism and the ability to shop on prices need to be regulated. So you can't shop for a different water.
I agree.
You can't shop for a different water company.
I completely agree.
Yes.
Yes. And I've always said it's not Medicare for all. It's not the system that we have today, which I would argue isn't really capitalistic.
No free market in healthcare. Yeah. But
there needs to be some level of restraint and transparency. And I think that'll create a competitive environment where people either have a set price or at least a benchmark that they have to compete for underneath. But at first, when you're talking about clogged pipes, I'm like, is he going down the path of like drain the swamp? Like, is that going to be the no?
So for people who are like, oh, socialism, you know, which I am not, I don't think there's anything wrong with some socialized public services, but I understand that this is a non-starter in America for healthcare. But what you're not talking about, so you're not talking about treating it like the fire department or the police where, imagine though, if the fire department like came to your house, it was on fire and you had to first pull out your fire card. Luckily we've all decided that's sort of a public service that's included in your taxes. That's not what you're talking about though. You're talking about, all right, I have to pay for things like electricity, gas, water. But I don't really have the ability to use but the one company or maybe two that are available to me. So there has to be some guardrails on what they can charge me and what the parameters in which they can operate.
Yeah, and this can very much spark entrepreneurship in many facets of medicine, allow the focus to be on quality, compete on outcomes. Don't compete on, is my price for a knee surgery $7,000 or $4,000, depending on what insurance my boss decided to give us. Like that, the randomness of that, everybody can agree on. Like that's absolute BS.
Mm-hmm. I agree.
Well, and I think we're not anti-provider. If anything, I would say
pro-provider.
Us collectively are pro-providers. We recognize that doctors have all been acquired, right? And there's obviously a struggle between them and many of the administrations. But I think that there has to be some sort of constraint or control on this need in every single community. With that being said, too, a large portion of these entities are not for profit as well. They're not paying taxes, right?
Not for profit's a hilarious word when you use it in the context of some of these companies. But yes, you're right.
We've had the hospital transparency rule for years now, and like 33% of hospitals are actually compliant with posting their pricing. Like that game has to end. And there are many components, there are many players within a health insurance plan that aren't innocent. But I would argue we need the fire department, we need the police department, we need hospitals to operate and function to save lives and treat people.
I mean, if it was up to me, I don't understand why we can't make a rule that says, all right, hospitals, you're going to act like other places where people purchase goods and services, and you're going to have your actual prices for the things, and those are the prices, no matter who buys them. And it's not a secret negotiation that somehow makes them cost more or less, but your price is your price is your price. And then you can, arguably, if that were the case, would we even need networks?
Whoa, slow down, Julie, with all your free market capitalist talking points. Like, where did you get these?
I know. I'm such a capitalist.
So I mean, that'd be fantastic, but we have the worst of both worlds. We have no access to pricing or gauges, national gauges on quality. We don't know what we're getting. We're just going either 25 minutes or 45 minutes to the hospital that we can get to in our situation.
Yeah.
So,
so we were talking before the camera went on about this wicked funny ophthalmologist. If you haven't seen him, his name is Dr. Glaucom Fleckham. I think I said that.
Shout out Dr. G.
Yeah. And so he's wicked funny. And one of the things he talks about is he had this medical emergency and he expected no bill because he had, really good health insurance coverage where he was employed. And he got a bill because the ambulance took him. He had full cardiac arrest. And so an ambulance took him and he was like dying to an in-network hospital, but all the providers who worked on him were out of network. It was the year before the No Surprises Act. And the insurance company was like, well, you shouldn't have gone there. He's like, well, which is arguably.
Let me pull out my crystal ball as I'm like having this medical emergency that's going to tell me where to go. Right.
He's a smart guy. He should have Googled while he was in
obviously.
Yeah.
You should know in advance and have it on your refrigerator.
Where the hell was Siri?
Here. I know. But this is how, remind me again, why networks are helping make the healthcare system work better. Because to me, you get stories like that. You get this situation where somehow I go to the same hospital as you, but I have one carrier network and you have another one, and we have the same thing done and mine costs twice as much. Why? How is this useful?
Wait, what's a network? I mean, it's the year 2025. I don't understand why they really still exist, except that there's a lot of people with 401ks that have United Healthcare stock and they have CVS stock.
That's a good point.
That's my only argument for we keep perpetuating the same system. Now with transparency, with pricing transparency, it hasn't changed nearly as much.
It's the illusion of pricing transparency. And I know I'll get slaughtered on LinkedIn for this, but How do you teach people to be consumers when like there are really no tools or the inability or let me say the illiteracy that exists with these individuals of understanding what their rights are, how to approach looking at prices? Most people just want to get care. That's why I love your utility idea. I think it's very, very smart. And I don't know anybody else outside of, I think it was a year or two ago, you mentioned this, that said that. But to your point, it's frustrating. And by all means, I have friends that work at the Bucas, right? I think there's some really great people that genuinely want to help folks, but the value proposition is struggling. And you mentioned it earlier with Dr. G, or that's what I'm going to call him, that he has really great health insurance. What is really great health insurance?
It means you're not personally going to have to pay for whatever monstrous cost something's going to be. And that's why the system is broken too, though, is because if you do have really good coverage, you know, the hospital knows it too. Everyone knows it. And this is an opportunity to bill at the highest rate possible because it's being paid for out of an unlimited checkbook.
Oh, I see you have the Amex Black Card here.
Totally.
Yeah, and they're free to pay whatever. And my point on great health insurance, what? Not only do I get to pay a premium that I split with my employer, but then I have these things called copays and deductibles and coinsurance. And this has been a hard market year. Like the renewals are unbelievable.
Oh, yeah. 30%.
30%. 93%.
No.
90. We got a new client that was like, hey, our broker told us we're getting a 93% increase and there's really no options. And it's like,
our broker told us our costs are doubling and there's no option.
It's like, holy moly.
Yep.
Now, like, that's a tragedy, not only for the business itself, but the people that are going to feel that impact. And maybe or not, there's a good underwriting reason. I don't know. But with this, I struggle with what is good health insurance, and we need to have a system delivered stat in order to save the crisis that we're in financially, and our health is suffering immensely as well, whether it be delayed care, right? Mm-hmm. Or the fact that like inflation is out of control, prices are out of control, people are making less, they're saving less for retirement, and now they're making very hard choices regarding putting food on the table versus paying rent or affording medications. That's why I think your idea is great.
And I love my electric bill. When it comes, it tells me like, you could save $1.03 if you unplugged all the things in your kitchen and, you know, your TVs. It's so specific on like what I spend every month, what I spend compared to my neighbors, if I'm doing a good job or like what I could do different. Imagine having that kind of granularity, you know, an explanation because we know what the prices are exactly in a hospital if it was regulated. And you could, that's how you become a consumer, is when someone explains to you how it works. Right?
Redirect all these jobs that are involved in pricing and repricing and negotiating and move them to, let's find value-added services.
But I don't want somebody telling the hospital what type of care they can give to me.
It has nothing to do with the care.
Yeah, but it happens now. Your network is how many appeals do we have to deal with? Multiple appeals, denials,
and prior
for life-saving.
authorization. Yeah, that's where they're interfering with the care.
Should have invited somebody that like likes how the insurance companies work all the time.
That's next week.
Where would we find that person? Honestly, who's coming on for that?
The hospital CEO, insurance
I don't think
CEO.
they like it either.
No, they don't.
I mean, unless you're one of the in the flush hospital systems, one of the major players that can dictate the terms of their contracts. A few of them may like it, but largely hospitals don't often benefit from these systems, particularly the people that work in those hospitals. And they're also stuck with the same health plans as we are.
We talked to a major hospital. You remember that a few years ago? And they're like, we need to figure out our game plan for getting out of the health insurance business.
Isn't that crazy? If a hospital can't figure it out, what does that say for the rest of us?
Yeah.
But let's go back and talk about what would it look like. So say it was regulated like a utility.
Yeah.
What does this mean? What could we do?
Yeah. So again, very strong interest in making sure it's aligned with the hospital's needs. The MedPAC survey is a big one that I rely on just to say, like, they study in detail what RVS, the relative resource-based relative value scale.
Oh, yeah.
That Medicare uses is very intelligent and well developed.
That's like where they get the physician fee schedule.
Yes.
Yeah.
So there's nothing more, accepted. Like some hospitals, it's 80% of their revenue. So they accept it nationwide. Wow. And Medicare for all is not what I'm talking about. What I'm talking about is approved and certified as not communism by every fiscal conservative that I know. Every actuary, every president of BUCA that I've talked to has said, if America really wants to actually impact healthcare for the better, absolutely hospitals need to be treated as utilities. That is the bottom line. If we don't go that, everything else is nipping at the corners, nipping at the edges. Like you can get drugs from Canada. You can you can have a really good out of network solution, but
and in fact, so Maryland already does this, right, to some extent. And now Indiana passed all these laws in the last year or two. And I think by 2029, their 5 big hospital systems have to offer direct contracts to any employers that want them that cannot that have a ceiling price that's like 260% or 280% of Medicare. Yeah. Whether or not that's a good limit is arguable and debatable, but that is sort of a start towards something like that.
Every RBP vendor is going to call you after this and be like, it should only be 130% of Medicare. That's it. That's the max. We'll
140
litigate
for the facility, 120 for the
We'll help with the balance bills.
I love all of them. They're my favorite, every single one. But the 100% of Medicare, what Medicare pays is different in different pockets of the country. So Maryland's certainly a little bit higher than the average, is adequate for efficient hospitals. So the bottom line is, do I have an efficient? So they've gotten away so long without being efficient.
Yep.
So many hospitals. It's just like a kid that's given a credit card and you don't monitor it at all.
Well, if you look at the administrative costs for a hospital, they've only skyrocketed. But why? They're not any more efficient. Have you ever been in a hospital time? Shit moves slow.
It does. And they're not putting money into the intake part and into the getting you in a room. That's for sure.
Listen, let me give you a recent example of a trip to the hospital that I made, and it was very scary. I learned a couple things. One, jalapeno burritos and old fashions do not do well for my body.
Have less than 10 in one day.
Less than 10. But the next day I woke up with the worst heartburn I've ever had in my life. I thought I'm having a heart attack. Mm-hmm. So I'm like, this is the big one, hun. Kim, call the ambulance. She's like, what do you mean? And I'm already dialing 911. Yeah. So they wheel me out. No place did they ever ask me about my financial situation, whether I was eligible for financial assistance, anything like that. It's just what insurance do you have?
Oh.
Right? Mm-hmm. And then obviously I trust the doctors to run the tests, right? And 8.5 hours later, I'm finally given some frickin' Mylanta, which cured me, right? Mm-hmm. It was a frustrating experience. And then comes the flood of EOBs and everything else afterwards. Hopefully they coded everything correctly, right? I look at what my responsibility is, what my plan paid, which was astronomical. It's just so inefficient is my whole point.
Yep.
Yeah, it is. But the idea of an efficient hospital also suggests that this is the problem, is if we treat health care as a utility, it's no longer a $5 trillion industry. And a lot of people have a vested interest in keeping it a $5 trillion industry because a lot of people get really rich in our current system. How much money a year do you guys think, if you take everyone whose job or a component of their job is repricing? And do you people know what repricing is? This is what repricing is, okay? There is some wrong price for everything that you get in healthcare. It's just a suggested price. It's sort of like the manufacturer's suggested price. And then usually an insurance company, sometimes an administrator, if there's no network, puts a different price on it. And they say, no, this is the price. Then another company usually comes in and says, oh, no, that's not a good price. This is the price. And then sometimes it goes out to a third company that says, we're going to make a resolution here. We'll put a price on this. So I don't know. What do you think? $1 billion a year? No, a 500 billion. How much money every year is spent on just changing the price of stuff?
And it's a flooded market.
It's ridiculous.
And more vendors are trying to do a better job, and they all charge a % of savings in most cases, right? So there's a VIG in there.
Which, does everyone know what that is? A percent of savings means, okay, the hospital said that this Band-Aid cost me $600. Somebody repriced it as $120, which still is very expensive for a Band-Aid. And then they took the 600 minus 120, and they said, wow, that's a difference of $480. And so we're going to take a third of that because look at all the money we just saved you. And then they add that to the 120 and says, this Band-Aid costs that much. That is, first of all, not a good way to run your health plan, and don't let anyone mix your fees with your costs. But it's ridiculous to take 30% of a difference in a fake price that you just slapped an algorithm price on or looked up.
It's happening nationwide every day, millions of times.
You know, we just reviewed an administrative a TPA contract, and you know the plan sponsor was all jazzed because on the proposal page it's a pretty nice, you know, per member per month fee or whatever. And then there were 21 pages. 21 page. I'm not lying. 21 pages of shared savings fees.
Oh yeah,
shared savings fees. And I'm like, yes, you're going to spend less on this fixed price. You're going to pay through the teeth on every single freaking claim that they touch. Mm-hmm. And it's rampant everywhere.
The worst I've ever seen, I'm sorry, I know we're interviewing you, but I'm going to keep talking, is this. Have you guys ever seen, it might be called something different in different plans, but it's called a traditional network savings fee.
What is that?
A no label network fee?
No, this is when you actually have a major carrier and you're paying a per member per month fee or a per employee per month fee to access the network, but they're also charging you a percentage because you're enjoying that savings. So you've purchased access to the network, and on top of it, you're paying a network savings fee. The first time I ever saw it, I called and I said, before I have an aneurysm, please explain to me what this means, because why would there be an in-network savings fee? Like, make it make sense. And the response was that it helps us. We put that money into other cost-cutting programs and cost containment programs. And I was like, well, put your own money into it.
Well, it's important. So that money is also necessary to pay the bonuses to the big brokers. Mm-hmm. So like they can't pay.
But we can't increase our administrative fee. There would be anarchy.
So you need additional percentages. So we have two local health plans. One of them has a patch on the arm of the Philadelphia Phillies locally here, and they are a nonprofit health plan that own for-profit subsidiaries, and those for-profit subsidiaries have traditionally had those additional percentages. So
that's insane.
Yeah. Oh, it's, you know, you'd have to read the contract to know.
You would have to read the contract, which is unfortunately where lots of employers drop the ball. And I understand if someone hands you an 86-page contract with a bunch of schedules attached, with a bunch of numbers attached, it becomes very cumbersome and you don't want to read it. But let me tell you, this is the most important contract you're not reading if you're self-funded. The idea that you're not negotiating the hell out of these administrative service agreements, you're really messing up.
And I know we're going to do a separate episode specifically on gag clauses and some of the things that we've discovered there, but I've never read a contract, whether it be ASO or PBM, that was clean. Like maybe one, and it's one that you probably wrote, to be honest with you. They're so chock full of BS. I just submitted one, I think it was yesterday, and it was atrocious. No explanation of how they're making money, just very broad statements, and then shared savings fees with no caps.
Oh my God.
Like we're going to charge you on this claim or claims, and there is no price limit to what we're going to take.
So back to the point I think we were at before. So if we were to regulate healthcare pricing like a utility, or hospitals like utilities, then that would eliminate an entire swath of fees that people pay every year to the tune of hundreds of billions of dollars.
Yeah. And those are wasteful fees that should not be in our economy. Those are, yes, there are some people being employed, but they're being employed to move paper from the side of the desk to the other and staple it. Like it's not.
Yeah, they're not sitting there like
helping the economy,
pushing an abacus around, doing the math and coming up with unique things, right? They're just like pushing a button. Yeah.
So,
you know what I like about this too is we know firsthand, because we've dealt in those populations where you have hospitals that are supposed to serve the community, right? That's the whole intent of a hospital. It's a place.
They would say that as well. Yeah.
They would say that as well, right? They'd agree. But we know that much like my visit to the hospital, there's not really good oversight on who's eligible for low cost, no cost care, things like that.
Yeah.
Like, is this a way to introduce that into the equation too and hold people accountable for the care that they should be delivering to the community? Because I think immediately of the impact to that Alice demographic, asset limited, income constrained, yet employed, who maybe are on a very horrible health insurance plan for their employer, or, they're out there and they're just trying to survive.
They're eligible for protections that have existed for many years.
Many years.
So the idea of price controls would also solve it's what is it, December 18th when we're recording this. There's a problem on Capitol Hill. They can't figure out what to do with these subsidies. The cost of those subsidies and the care that the insurance that they would be paying for, it's a transfer from the American taxpayer to the large insurance companies, paying for their bloated, inflated prices that are built into those premiums that they're subsidized. So if we knew, okay, we're going to rein in the most extreme, most expensive, like the reason you have insurance is hospitals, not because you go to the doctor 4 times a year. You don't need insurance for that.
Right.
You need insurance if you go to the hospital or you have a really expensip drug and we don't have time for drugs.
Agreed.
So we'll talk about that later. My one point about drugs, there's a lot of innovation, R&D, but there's an apocalypse, the end of the world is going to happen at some point. So if that's 2080, for instance, sometime between yesterday and that apocalypse, we should regulate drug prices. Now, I don't know if it's 5 years before the apocalypse, but let those last years on Earth be price regulated so that people can have easier access to drugs. So that's my only comment on the drug.
Yeah.
I would agree. As a former drug rep that sold a multi-billion-dollar drug with 7 competitors branded and multiple generic alternatives, it's a little crazy, right? We need R&D, we need research and development, but there's no reason. And I'll use an example. We got a client right now with three branded medications, same drug each month. Each fill is roughly $23,000. Every other country limits the price to $4,000 a month. Like, why should we be subsidizing that?
And also, isn't a lot of R&D already paid for by our tax dollars and it happens in our universities before the drug companies even get it? Don't we already fund a lot of this?
That's true. So back to you've exhausted my prescription expertise today, but back to the hospitals.
We'll have Mike Mealy back for that.
If you can look at reducing those most extreme things, that the reason you buy insurance for, those premiums that we would subsidize would be significantly, we would save taxpayers so much money if we were able to immediately do that. Like, that's not going to happen with a snap, but it would solve a lot of that problem, and there would be so many more people covered. Like, employers could afford to give their nursing home employees or their retail or their restaurant employees coverage, because all of a sudden, premiums are significantly less. So many more people now have that insurance, and the hospitals could compete on quality and things that they should be competing on.
Oh my gosh, quality. What are you talking about? I know that. Imagine that.
It exists.
Yeah, that's how, and that, I'm sorry, but when we're talking about making consumers out of healthcare purchasers, that's what most people care about is, can I go to a hospital where they're not going to like drip MRSA into my open cut? That is the type of shopping that I want to do, because as somebody who got MRSA in a hospital and had I did, and it was terrible. And, that matters a lot more to me at the time something is happening than how much it's going to cost. When you have to have surgery, you're much more concerned about, will I live through this, than how much is this going to cost?
Yep. And I'm a fan of entrepreneurship, and I'd like tackle outpatient issues at a later date. Fixing the inpatient, like those most expensive things, you can't control. The things you can shop for, knee surgery even, but lower things like that, like your doctor, your vision, things that you can take time to think through that are lower dollars, that it makes a difference, $100 or $300, what I pay for this particular service. But when it comes to things that there's no consumerism, there's no price shopping.
It's the $1 million NICU kit. It's the cancer treatments, right? We go into site of care issues. It's just the exorbitant billing for things like freaking tissues or Tylenol, like you said earlier.
And as we're heading into a hard stop loss market, Like it is hardening, and
Heading into,
there might
we're
be,
here, babe.
It's going to get worse, and you'll know it by more carriers going out of business or MGUs going out of business. So like that might be happening. It might not.
Yeah.
Like anything could happen, but like those companies as well, those CEOs of there's some that just enjoy the 3%. Margins on an ever increasing number. But the vast majority of them don't like the crazy fluctuations of the shock claims that could absolutely destroy their year. The $20 million claim can destroy their years. So to have some certainty around that and then compete on the solutions, a point solution, like the entrepreneurial stuff that you can now enhance your plan with because you have extra dollars, there's a lot of potential innovation.
Well, it involves a pretty large mind shift to get plan sponsors over to that. But once they make it, it's like, they've seen the light. Sorry, Julie.
So no, don't be sorry. So we have to take a break for a minute, but when we come back, I want to introduce one more radical idea to add to potentially what could be a regulated utility and see like if we think like, I don't know, I think we should put all the things we think the regulations should be on the table and then consider what that would do to the cost of healthcare and whether or not we should be going to Congress with this stuff immediately or what. But I mean, it's not rocket science, people, because if it was, I wouldn't be able to do it. Uh-huh. And we can just eyeball this. And I'm sorry, but in a system where you've got people, especially if I'm going to pay someone too much money, I want it to be the surgeon who puts me back together. I don't want it to be the person who decides how much that surgeon gets paid.
Love it.
All right. So if we were going to regulate hospitals as a public entity, let's just talk about what that would look like or what it could look like. It doesn't have, there's more than one way to do this. What's like the first thing that would be a regulation for hospitals? It would be that the prices, right?
Yep.
And would it be actual prices, or could you say, okay, you have a ceiling and a ceiling on prices, or would it be actual prices?
You could have a ceiling, but then the prices are going to generally hit that ceiling unless the hospital's not necessarily paying attention.
But that's actually not completely a negative, though, right? Because if you have something that's like 3,000% of Medicare allowable now, regulating that will be a positive.
Yeah,
Could be.
And if there's a ceiling, so like the Indiana law that we brought up earlier, they're going to have where they're public hospitals where I think they'll have to offer contracts that are like maximum 260% of Medicare. I keep changing the number. It's somewhere.
Yeah.
So if that's the case, then isn't now the game there's the competition is don't be at that max.
We're half of the max, especially for those MRI, for things that people actually have to pay out of pocket for. Mm-hmm. Oh, if I go here, they're advertising that they have a more competitive price, same result, same quality, same outcome.
So that could work. Although for you, best way for if we're going to regulate hospitals is the prices. Like the prices are going to be based on how they price the Medicare fee schedule, but not that price is going to be some percentage of that, but that's the price, and the price is the price.
Yep.
And no matter what, do we all agree that part of regulation is that a hospital is going to have the same price for everyone who goes to it, unless you qualify for a discount because you're low income. But other than that, or unless you're on Medicare or Medicaid, but for all private payers, whether you're self-pay, your employer pays, you bought a policy in exchange, whatever, your knee surgery costs the same amount.
You want that random discrimination to just go away. 100%. It's just so random. Like, oh, I have Cigna. My neighbor has that. No, my other neighbor has Blue Cross, and you're all paying different amounts. Like there's nothing different outside of your employer made this choice last year.
So let's talk, and this is something Julie and I talk about. Who are the winners and who are the losers in this scenario? Who are the clear-cut winners?
Okay, we only talked about one rule. We'll come back to that, but let's start with the winners. Obviously,
Consumer, plan sponsor.
There's only one loser.
Yeah. There's only one loser. Yes.
It's not stop loss. It's not the PBMs. Nope. The hospitals, maybe this will help them with administrative burden. I don't know.
It would hugely help with administrative burden.
Yeah.
And they don't have to negotiate with carriers anymore.
It's the networks. Yeah. It is the networks.
That's the one loss are the 5 to 10 companies that have these huge network agreements that they gatekeep and, keep secret. Those are the largest companies in the world, not just this country, but in the world. And they're the only companies and the only entities in this whole system that we have that make billions of dollars in revenue every year and billions of dollars in profits.
Payviders included, those that operate both as a provider and a health insurer.
Yeah.
Yeah.
I was in a room with Mark Cuban and the CEO of Optum 2 days ago at Johns Hopkins, and it was interesting. Mark, love him or hate him, he said a few times, why don't you publish your prices? I want to compare my prices for drugs from his mail order. He owns a pharmacy. So he has a pharmacy that has clear prices that he discloses, and Optum does not disclose their prices. Mm-hmm. So he was saying, why don't you disclose your prices? He asked like 5 or 6 times, and it changed the subject every time from their side because they have different prices. Now, Optum did say, our prices are better than your prices 100% of the time. Our team checked, like every single one of our drug prices is lower. He said this in public
maybe
forum.
Today until they manipulate NDC codes and...
Well, the thing is, if you have broker comp of $9 a script, and then you have the pharmacy consultant at $11 a script, that's going to be a different price. So they can't disclose their prices because then people would say, well, why did I pay $650 when they said it should be $620? Well, because the broker and the PBM consultant got a piece of this. So that's just one factor that could change the price.
So just make sure everyone understands this. What they're saying is that, okay, so Optum might technically be right that their prices per drug are lower than the prices if you buy it from Mark Cuban's pharmacy. However, what's not factored into that is the amount that the broker who placed that contract will get. If you have one of those contracts that's through a consortium, the amount that they will get, the amount that all these other...
The TPA.
All the other vendors in this space add on to that. And so when you add that all together, is it still cheaper? Probably not. But back to...
Good luck getting the data. To your point,
Yeah.
you can't get that data from the networks and the PBMs. I'm not trying to make boogeyman out of them, but like they're in this spot and they wanted to blame the drug manufacturers primarily in that room. But we need drug manufacturers. Why do we need PBM? Could we just buy drugs in a different manner?
Aren't PBMs the same as networks? Like what we're talking about? They're just these middle... I don't want to call it middle things, middle people, not middlemen, middle entities set up to gatekeep between you and the product you're buying, that for some reason you have to pay them a chunk if you want to access this product that you should have access to because it's for sale.
So there are clear-cut winners and losers, right?
To the winners
and the regulation of pricing is a component of this. Hospitals as a utility.
Yep.
What are the other components that have to? Is it state regulated? Is it federally regulated?
Well, if it's state regulated, then
it's going to be hurting
states
cats.
are going to have. Yeah, it's like right now Maryland has some sort of regulation that keeps prices in check, and I think in Maryland the rules are that. They have a rule that everyone pays the same price, right? That all the carriers pay the same price. So. There's other issues in Maryland. I live there, so I know this, but that's not one of them. Mm-hmm. And so that there's, the prices, there's no reason for big spreads when you see on the individual market because they're all paying the same price for the actual services that you get at a hospital. And I think Maryland has reported like pretty good results in that no hospitals go out of business.
Their outcomes are good.
Yeah.
Johns Hopkins, everybody's heard of them.
Yeah.
Like they've managed to become efficient under that fee schedule.
Yeah.
And outpatient provider, like that it doesn't regulate outpatient providers. So you can have surgery set, like there's areas for venture capital and private equity to win. There's areas for innovation and entrepreneurship. Like it would, if anything, supercharge those industries, those areas of industry to focus on what needs to focus on delivering for consumers. And then we get to who's the big winner? America. How about that? Are you a fan of that? Like
America
versus the other countries that are vying for top country in the world. So like it is a distinct American weakness, our healthcare system and how much we spend, and we're always the lowest quality, the lowest possible outcomes out of the developed nations and what we get for our dollar.
And I think people can confuse quantity for quality. We have a ton of healthcare stuff, right?
Stuff.
Yeah. And we spend more than any other developed nation, more than the GDP of many developed nations. But you're right. It's the quality and the outcomes, and that has to change. And I think it's primarily because it's not, the financial aspect of it is not regulated whatsoever.
None of it's regulated properly, to be honest.
And incentives are super misaligned all over the place.
Yeah.
100%.
in a country where life expectancy is going backwards. I mean, we are just all messed up. And we need to make
People can't afford to have babies either because healthcare is too damn expensive.
Yeah. And I wish we had our own like Jamie to look this up because there was some stat the other day, but I can't remember the exact percentage. But almost like half of Americans, and this is where I need someone to fact check me, but like a large chunk of Americans don't go to the doctor because they can't afford their deductible payment. Of course. So your employer is paying, $20,000 a year at least for your coverage. You're paying through these, payroll deductions. And you still can't go to the doctor because you can't afford the deductible. So it's absolutely absurd that the way our system currently works. And there are like 5 to 10 companies that are raking it in and making billions of dollars a year. And then you've got, most Americans deciding whether they're going to fill their prescription or eat that week, or whether they're going to split pills with their spouse because they can't fill both. Like there's no reason for it to be like this. And it's not like this anywhere else. So there's no reason for it to be like this.
That there's going to be a big fight on Capitol Hill, and they're going to say that this is socialism. You can't turn it into a utility. It'll be the downfall of us all. That fight will come, but I think this is a good argument to make.
And electricity still works. So does water. Yeah, it didn't downfall any of those. I get gas. And in fact, the only utility issue I've seen over the past 5 years came out of Texas because they had an unregulated utility situation. Oh, and there was a storm there. And all of a sudden people were like, their electric bill was like $2,000 or something crazy because they didn't regulate it properly. And so however, so there's the argument is that all of the naysayers will say, well, those are all regulated on a state level. And so what do you say to that?
I mean, they would have to be adjusted by state. So certainly, just like the current Medicare fee schedule, whatever these, if a fee schedule were to, it's hard to imagine it actually getting there. But if it were to happen nationwide, that would be the best chance for us to fortify our country as a leading world power, is to all agree as a nation federally to do this.
Yeah. And really think it could be more like a partnership the way Medicaid is, in that states obviously are going to have some different things that apply depending on where you are. For example, if you're a state with like a huge rural population, you might have to make different types of payments to ensure that rural hospitals stay open. And so, there just are going to be different payments for different types of hospitals, right?
Yep.
But that doesn't mean that you can't have a sort of national program that you set up. This is how we're going to regulate this industry. Are there any other national industries the airline industry, right?
Yeah.
And to your point, the MedPAC study I referenced earlier specifically says there needs to be $4 billion of targeted reinvestment because of those poor distribution of Medicare reimbursement rates to specific rural hospitals and other, it's not just rural hospitals, but that's a good example of, rural hospitals.
I want to get Bernie Sanders in here.
Oh my God. My dream.
Yeah.
Although
we've got to make it a utility.
No, he would say it was Medicare for all, which,
I know.
In a perfect world, Medicare is a really efficient system. There's low administrative overhead, but I understand that America doesn't want it and it's not going to happen, or at least not right now. And so at least regulating it, which like we do every other industry, it doesn't have to be. It
doesn't have to be onerous. The goal would be to make it not onerous.
Yes.
Yeah.
To benefit consumers, to benefit everybody in the community.
Everybody. And honestly, every single day, if you watch TV or YouTube or whatever you're watching, there's some like just last week, there's the story where United denied the guy's health care and then, on pre-auth, and then they overturned it on appeal, but he was dead already. And
handle it every day. This week, I handled a case where somebody had a life-changing surgery that got denied.
Yeah.
Meaning they're now able to walk like they couldn't walk before.
Wait, so they paid out of pocket, had the surgery, and now the carrier won't reimburse them?
100%. Was it medically necessary?
Yep.
Okay. Who told you it's a walking?
It's just, I can't get into specific details.
But are you saying that the carrier's argument is that walking is not medically necessary?
It's coming down to a disagreement in coding, and it is absolutely absurd. And just when you think you've seen it all, right, you see something else that makes absolutely no sense. And maybe, just maybe, hospital as a utility eliminates that.
So while we're regulating and turning hospitals into utilities, there's two other things I want to talk about this. First of all, what about 340B and all these, what would we do about that? And for everyone, 340B is this congressional program that allows hospitals to get drugs at, I don't know if I'm even explaining this right, at like a discounted price, but they don't have to pass on that discounted price to the people that get the drugs from that hospital. And in fact, it's sort of like a profit center for them because they mark them way up, just like, they do everything else. And so I think the purpose or the intent was to offset some, Medicaid expenses they have and to do other things, but it's really, it appears to be an out of control program that most people would like to rein in. So how would we regulate that as part of this?
340B, or are you asking how do you
would
prevent?
340B be subject if hospitals are utilities? Wouldn't 340B have to change? Wouldn't that?
Yeah, it should change. It should become more transparent. In some ways, I'd say it could expand, but
I think with any regulation too, there could come the ability to bastardize it and for people to seek out ways to profit from it. So like I think about a typical surgery, right? There's usually a separate anesthesiologist bill, right? Like now do we make anesthesiologists the new NICU? Like $1 million for anesthesiologists, and that's their new profit center. It has to be kind of regulation across the board.
The ERAP providers would need to be looped into that hospital, right? So that would be the one specialty category that I would say needs to be part of that institutional reform is ER, radiology, anesthesia, and pathology.
What about like?
So wouldn't it arguably, though, if we're doing this and it becomes a utility, there's no more networks. So they're all in network and all the prices are the prices. And if you want to be an anesthesiologist at this hospital, this is the price. And, that's how it works.
Yep.
I think that's a good solution. And then what about ambulance rides and things like that as well? I mean, I know a lot of people, family members included, that have avoided calling 911 because they're too afraid of the ambulance bill.
Yeah.
I mean, we used Uber when we had like a semi-emergency and we're like
Uber ambulance.
Yeah, because the other thing is under many plans, if you go in an ambulance and they don't admit you, it's like it might not be covered. It might be way more expensive.
The hospitals now can stop focusing on sending people to collections or negotiating with insurance companies or worrying about outlier payments. They can focus on delivering better care. They can focus on competing with, hey, we have the ambulance that's reasonable, or we have, but yes, that.
To be honest, I don't understand why EMTs, if you need an ambulance, to me, that should actually be like police and fire. I mean, because that's an emergency and that should even be worse for many of you than, treating it like a utility. Mm-hmm. It should be included as part of your taxes if you need an ambulance. Of course, if you call it frivolously or something, then you could, just like if you, pull a fire alarm, you can get in trouble and have to pay for it and things like that. But if it's an emergency, it should arguably be part of what we pay taxes for. Just a thought.
Well, because we pay taxes. A lot of the hospitals don't pay taxes. Yeah. And so there's this.
You pay taxes?
I do. I do. It's
I didn't
frustrating.
know that was a thing.
Yeah.
Mm-hmm.
I think we've covered a lot of ground in this discussion.
But I got one more thing that I want to add to this. So,
please add.
All right. So say we're going to do this and say, okay, now hospitals are utilities and we just saved, I don't know, maybe like half $1 trillion a year.
That's what I would get, something like that.
Okay. So that's a big savings. That's a good start. Nice. Way better than what Doge did, I'll say. It's a lot of money. So
I'm still waiting on my Doge check.
You didn't get one?
No.
Oh.
Been holding my breath.
Well, if you guys are veterans, you'll get $1,776. I just heard that.
I'm not a veteran.
Okay.
But God bless our vets.
Yes, and they deserve it. So anyways, another area where, so if we added this on, how much money could this potentially save? So now we're all making, insurance, everything's going to cost less because
it's logical all of a sudden.
I know.
Yeah. Yep.
So one problem we have in this country is there's no more primary care doctors. And no one wants to be a primary care physician because they just cannot stand.
I got talked out of it. I was pre-med. I had a
doctor.
Yes. Yeah. That's what my degree's in. I had a doctor, Dr. Chadwick. And she's like, so you're thinking of being a doctor? She goes, I'm not going to be in practice independently in a year. I'm going to have to sell to UPMC. She's like, there's no way for me to keep this going. You know, most of them get into practice care, and the volume of patients they have to see due to reimbursements and everything else that they invest. She's like, if you do this, like, be prepared to take on a lot of debt, and you probably won't be able to be independent.
So here's what I'm thinking. Okay, so we need more doctors. That's one thing. We have to encourage people to go to medical school. We don't have enough doctors to see all the people in this country that need doctors. So how are we going to do that? One, we have to liberate doctors from having to deal with insurance carriers all day because it's making them miserable, and they either then work for them or they leave entirely because or they go into a specialty where they can make more money. So then, you know, I am a huge fan of direct primary care. I think it's great, but all you hear is people say, well, that's concierge care. Only really wealthy people can afford it. Well, it's wicked cheap. Okay. And it's like, you get, at least from what I see, it's way less expensive than many of the types of things people pay for in their health plans now. So why isn't so say we were ever going to do sort of something for all, why not have direct primary care for all? It could be funded by something, a tax that employers are going to start
the savings from
money.
The hospitals becoming a utility could be redirected into direct primary care
Just
for
a
all.
portion of them.
And that'll keep people out of the hospital, and the overall economic burden of people not going to the doctor and ending up in the hospital.
You mean moving from a sick care system to a preventive and like ongoing treatment?
Your ideas are extreme. Yeah.
So those two things put together, and it might cost a little bit at first to do this, to implement the primary care for all. But once you've done that, you're going to start saving money because people will go to the doctor and get preventative care and have chronic care management and do all those things. And so you'll have lower hospital utilization, less surgeries. We'll have lots of improvements. So now we're talking what? Maybe like $1 trillion.
That goes against the shareholder value in some of these entities that have a perverse interest, mainly, once again, the loser in the equation, which would be the carriers, right? I think this is a genius idea, Julie.
I like it, but I don't know. I'm sure there's plenty of people that could poke holes in it, but I'd like to hear what they are, because I think we have to do something to make sure we have primary care.
Yeah, the alternative argument is no, let's do nothing and keep doing this. And I'm caring about my children. So my children and my children's children, like, all right, maybe we'll survive all this nonsense of 15% rate hike every year, but like, how are we going to have a sustainable, good healthcare system for the next generation?
Here's what I don't understand. So this year, huge crisis, right? And everyone, not only about the subsidies being lost, but the fact is, the price of healthcare apparently is going up for everyone by somewhere between like 9 and 15% just for like getting healthcare. Why? What has changed? What is different?
It's probably the egg prices. It's driving everything. I'm joking.
I know.
But I mean, it's ridiculous. I mean, you'd add that on top of the inflation that we're dealing with, and the fact that people aren't making more money. Like, this is a crisis nationally. And to your point earlier, yeah, people are making some tough decisions. They're, do I go to work? Do I go to the doctor? Mm-hmm. Do I go to work? Do I put food on the table? Do I pay my rent? Do I pay for this medication? Like, it shouldn't be like that in the United States, but it is.
It shouldn't be like that anywhere.
Agreed.
But yeah, here we're the richest country on earth, and arguably full of people that are smart. We can do much better than this system, like way better. Even
smart, but Buffett, Bezos, and Diamond with, what was that crap project, Haven?
Yeah.
Couldn't figure out how to navigate.
I think JP Morgan realized all of the big carriers had bank accounts at JP Morgan Chase. So and then Berkshire Hathaway invests in DaVita. So there's that conflict. I think Amazon was the least conflicted.
And that's like the greatest. I'm so glad you just said DaVita. So like now we've got regulated hospitals. And so now all of a sudden you're not hostage to the 2 dialysis carriers that charge you an absolutely absurd amount for kidney dialysis, because the price of dialysis is going to be regulated unless you go to a freestanding center. And so they'll still have them, I'm sorry, but It's like some Fresenius just opened near where I live, and it's in like an abandoned furniture warehouse. I cannot understand how it can cost so much when it's in such like a strip mall, terrible location.
DC has the biggest prevalence of kidney disease. So
Really?
Wow.
That's why they're everywhere.
Wow.
that's why they're finding every nook and cranny they can fit
I was
themselves
like,
into.
this does not look like a place where it should cost. What is the percentage of Medicare that it costs?
So, like the wild variation. It's
Super
thousands.
expensive.
Yeah.
10,000 times. It was something absolutely absurd. No, my numbers sound sort of like 600% or something, way more expensive.
But they'd be willing to receive 10% of what they're asking. And
Yeah.
I got a single case agreement for somebody going to a residential facility the other day, and they were trying to get $8,000 a day.
Oh my God.
And we checked prices because we have access to pricing data, and we proposed under $800 a day, and they signed it within half an hour.
It's wild.
So
$8,000
people are
a
being
day.
taken advantage of,
That's ridiculous.
and that drives me nuts.
How is that not consumer protections violations and
or a crime,
It goes under the law of it can't hurt to ask.
God.
Yeah. But we shouldn't have to ask. And so that's why we have to do this. And so today we just talked about like a couple simple things. The most simple is like, if we treated it like a utility, we would easily start saving.
specifically hospitals, treating hospitals.
Treating hospitals
as
like
a utility.
utilities. It would eliminate a huge chunk of the industry that does absolutely nothing of value, which is just change the prices on things.
It's the first and only step to really reforming the system.
Yeah.
But it's the first step.
Mm-hmm.
It's many things could follow.
Well, and next episode, we're going to bring on you again and then the American Hospital Association, and we're going to have a chat.
I don't know. Are we sure? I mean, I'm sure they don't want to be regulated like a utility, but would they hate getting rid of networks? Would they hate having to like negotiate every single few years? All of them wouldn't hate it. Some of smaller, I don't even understand.
I don't know. I'm connected to a few AHA folks on LinkedIn. I'd love to hear from them. Have them, reach out. Would you be for or against this, and why?
I hate to be this person, but like, debate us, bro. Like,
Yeah, come at me, bro.
Yeah, come on and tell us why the system we have now is better.
Yeah.
How it works better for the 365 million American people that we have, than what we have now, than what we're contemplating. Because we get it. It works for a few people, but for the vast majority of us, it's literally killing us.
Well, David, we think you are one of the smartest folks that we know. We're honored to have you on as a guest on the EOB, and you've helped explain some benefits today, which we appreciate.
Yes, thank you.
Thank you for having me.
Of course. Well, I'm Justin Leader.
Julie Selesnik.
Thank you for joining us.
We'll translate the jargon and call out the flaws. No spin, no sales pitch, just what benefits folks should know. Health and welfare, decoded, let's get into the show.